Hello everybody, my name's Mark Snazelle. I'm one of the intensive care consultants here at the William Harvey. My brief today is to speak to you about lung recruitment in 20 minutes, which will be a little bit of a challenge. Nonetheless, my brief really is to try to keep this relatively simple, talk about concepts, try not to go into too much exhaustive detail. Now, having said that, we're going to be covering this again this afternoon in the workshops, okay? So you're all going to get a chance to do some recruitment manoeuvres on the ventilator, assuming they will work, and use the PV tool. So I don't want to go into too much now about what settings, for example, that we use. So we're going to talk about that this afternoon. So basic principles in the lecture, and then some practical experience later on this afternoon, okay? Right, so what are we actually going to talk about today? We're going to talk in brief a little bit about some of the physiology, and then talk about recruitment itself and why do we need to recruit the ARDS lung. Evidence, I'm not going to go into vast amounts of detail on either, you'll be pleased to hear. We are going to touch upon that. The main part of the talk really is going to be talking about recruitment manoeuvres. Why we do them, how we do them, when we do them, etc. Gemma's already talked about our refractory hypoxia pathway. I'm going to mention it briefly at the end. And that's the broad outline of what we're going to talk about. Now, a little bit of physiology. I'm sure you've probably all seen this slide. It's a well-used one. ARDS lungs, okay? So for those of you uninitiated in CT scans, which I'm sure is very few of you, but anyway, just the very basics. So bottom of the lungs, top of the lungs, what we've got is lots of consolidated, collapsed lung down at the bottom here, lots of secretions. Where's the normal lung? Anybody? Is there any normal lung there? Just a bit of a clue. So this isn't normal either here. There's certainly some fluid there, some consolidation. The normal lung, which actually isn't really normal now, is this bit, or at least it was normal. Why am I saying it was normal? So have you all heard about this concept of the baby lung in ARDS? So you've got a lot of the lung is abnormal, collapsed. What small amount of lung you've got left that is normal is preferentially ventilated when you put them on a ventilator machine. So what happens? That small baby lung gets over-ventilated and is therefore subject to ventilator-induced lung injury. Okay, so how do we get around this in terms of ventilation? Well, one way clearly is to put the patient on ECMO and not worry about the lungs at all. But that's not applicable to every ARDS patient we're going to have. There will be some that whatever you do ventilation-wise, that's what you're going to have to do. But surely it makes sense, doesn't it, to try to recruit some of this lung, open it up, and use it for gas exchange, okay? And thus take the strain off the over-ventilated baby lung. So that's broadly what we're trying to do, and that's what we're going to be talking about now. What is recruitment? There is a definition, which I'm going to just read out to you actually. So the use of a transient increase in transpulmonary pressure to reopen previously collapsed or non-aerated lung units. That's exactly what we've just been talking about. So lung that's collapsed down, previously not usable, utilisable for gas exchange. We're going to open that lung up and use it. What are the limitations of this? We don't really know what the chest wall compliance is in patients. It varies from patient to patient. Difficult to know and measure objectively exactly what it is. So how much of the high ventilatory pressures that you're or you may be seeing in ventilating these lungs, how much of that is due to stiff lungs, how much is due to stiff lung wall? A bit difficult to know. So possibly that may go some way to explaining why at the moment there is not, shall we say, a robust body of evidence when you start talking about recruitment. There's certainly an emerging body of evidence, I think it's fair to say. We'll talk a little bit about that in a moment. What is it we actually want to know when we're ventilating somebody? What we really want to know is what's the alveolar pressure. We want to know that our alveoli are awake, I was going to say, are open, and because that's where gas exchange is happening. How do we measure that? Well, we can't. There are ways of approximating it. So, oops, sorry. I'm not going to talk any further about this, but there are transpulmonary pressure catheters that you can use. We don't have them here, but there are ways of approximating alveolar pressure, and certainly at lunch, Mike, the rep, I think may have some catheters that you can have a look at. This is a way that you can look at trying to approximate alveolar pressure and trying to perhaps set your PEEP to keep those alveoli open as best you can. But we don't have that. I'm sure probably most of you in your hospitals don't have that. And I pressed the wrong button again. Good. Okay, so this is an important slide. So everyone here is familiar with PEEP. Everyone is here is familiar with recruitment. Are the two the same? Are the two the same? No, they're not. And I think that we need to just reinforce this point. So we need to get away really from thinking of PEEP as a recruiting force. PEEP is what we utilise to keep the lung open. We need to open it first via a recruitment manoeuvre. So you can think of PEEP as anti-de-recruitment, all right? So keeping the lung open. But just by increasing your PEEP, you will not adequately recruit lung. There will be some degree of recruitment, of course. But what you need to do is you need to do a dedicated recruitment manoeuvre to actually actively open the lung up properly and effectively, and then keep it open by utilising PEEP. Now, we talked at the beginning about evidence-based. Now, you'll be pleased to hear I'm not going to go through lots of slides on different papers and etc. And I'm not going to speak a lot about PEEP. And the reason I'm not going to speak a lot about PEEP is that any of you who've been going to intensive care meetings over the years will know that PEEP has been the subject of much discussion really for decades. Agreeing what it is, what it's for, how to set it, how much to use. There still remains a lack of consensus actually in terms of, you know, how to use PEEP, how to use best PEEP. I think what's becoming clear, however, over time is that we are probably all underutilising PEEP. We're probably all underutilising recruitment. So I'm going to move on from that and talk about recruitability now, and that's going to be the main focus of the rest of the talk, okay? So this is really a key question, and Gemma's already spoken about it, about this issue of recruitment. Is the ARDS lung recruitable? The answer to that is not always. So Gastononi has done a lot of work on this subject, and you may well be familiar with this slide, looking at some ARDS lungs. So what we've got here is two different patients, one at the top, one at the bottom. On the left side here, you've got lungs subjected to 5 centimetres of water pressure, okay? And then on the right, 45 centimetres of water pressure. And what do you see? Well, let's take the one at the bottom first of all. So we start off with a picture very similar to what we saw at the beginning. So collapsed lung down here at the bases, fluid in there, collapse, consolidation, poorly aerated lung. Subject them to 45 centimetres of water, and what do we see? This lung starting to open up, okay? So this lung has become recruited. We've successfully recruited that lung. But look at this one. Starting off here, at 5 centimetres of water, again, we've got our collapsed, consolidated, mucky area of lung at the bases here. 45 centimetres of water here, not a lot of difference. This is really important, okay? So not all ARDS lung is recruitable. There's been lots of work to try to explain this, and I think it's fair to say that this still isn't fully understood. The concept of extra respiratory ARDS versus respiratory ARDS, I'm sure you're familiar with, but is the cause of the ARDS from the chest? Is it from somewhere else? There is some evidence to suggest that extra respiratory causes are more likely to result in recruitable lung. However, this is important, that doesn't mean that ARDS from a respiratory cause isn't recruitable. Okay? Likewise, lobar versus non-lobar. Probably the non-lobar, more generalised picture is more likely to be recruitable than a lobar picture, but that does not mean that someone with a more lobar ARDS does not have recruitable lung. Okay? Probably more importantly is this one, time from the beginning of disease. So what is becoming increasingly clear is that the longer you are through your disease process, the less likely the lung is to be recruitable. So the lung becomes stiffer, fibrosed. You're not going to be able to recruit the lung. You need to do it early. Okay? So this is important. All right. We talked a little bit about chest compliance already. So how do we assess recruitment? There are various ways of doing this. So the gold standard really is to do CT scanning. So what do? Scan the patient before your recruitment manoeuvre, CT scan. Do your recruitment manoeuvre, set your PEEP adequately, put them through the CT scanner again. Have a look. See, we've seen some CT scans already. Is that a practical solution for us in the District General Hospital? Probably not. Used experimentally mainly. Lung ultrasound, something that's being increasingly used, and I'm sure many of you have seen this done. You know, some degree of interpersonal, sort of variability or reproducibility is difficult. So, you know, there is variation between operators. So what other ways can we do this slightly more reliably? And what I'm going to talk about now for the rest of the talk is the PV tool on our Hamilton ventilators. What was this slide for? Yes. So we've actually covered some of this already. We've talked about the need to use recruitment early on in ARDS. This is an important point here. Hemodynamic stability. So clearly, your patient who is very hemodynamically unstable, you're potentially talking about exposing them to a recruitment manoeuvre, high transpulmonary pressures, okay, intrathoracic pressures. Probably not a good idea in your very unstable patient, because what are you going to do? You're going to reduce venous return, etc., etc. So we'll talk a little bit about that again in a moment. But what can we do to assess recruitability rather than just go ahead willy-nilly and do a recruitment manoeuvre? All right. So I'm going to talk now about how we do that, how we can do that using the PV tool, and the way that we've been taught as a unit to do this. And it's a technique that we're increasingly starting to use, is by using the PV tool to do an inflation and deflation curve, which I'm going to talk about in a moment. So I should point out I don't work for Hamilton, okay? Can I just ask, from the floor, how many of you actually use Hamilton ventilators? Okay, good. So most of you will be familiar with this, this picture then. So this screen is what you get when you press the PV tool on the ventilator, okay? So you can use this tool to do your recruitment manoeuvre, but you can also use the tool to test for recruitability. And it makes a lot of sense, as I've just mentioned before, that rather than subject someone to a potentially injurious manoeuvre, particularly if they are not recruitable, rather than just go ahead and do it, which is probably what many of us have tended to do in the past, but actually if there's some way that we can assess whether or not that patient is recruitable, and that's useful information. Do that first, assess whether they're recruitable. If they are, go ahead and do the recruitment manoeuvre. So this is these are the numbers that we tend to use. So this is the curve here. So inflation limb, deflation, okay? And what we do is we start at 0, set a P top, or the top pressure, at 40. Sounds quite a lot. But we don't wait at 40, so there's no inspiratory hold here. Go up to 40 slowly open the lung up, and then come back down again. And there are 3 measures that you can use to assess whether or not that lung is recruitable by using this tool. And just to reiterate, we're going to go through this afternoon in the workshop, so you're going to get to have a go at this, and we can talk about these numbers again in the workshop, okay? Okay, so the first thing is the shape of the curve itself. Oh, sorry. So many of you will be familiar with the term lower inflection point, maybe you're not. Lower inflection point, it comes up here on the graph. What that refers to is this point here. So on this curve, you can see that pressure on the x-axis, volume on the y, okay? So you start to increase pressure and volume goes up. So the curve starts off relatively flat, and in the recruitable lung, what happens is you'll start to recruit lung somewhere around about here. And rather than a straight line, which you'll see in a non-recruitable lung, you get this sort of pattern where it goes along and then starts to go up, and there's a point here where the gradient changes, and that's your lower inflection point, okay? So if you get that kind of picture, that kind of curve on the inspiratory limb, that's one thing that suggests that lung could be recruitable, okay? But only one thing. Second thing we look at is hysteresis, okay? Which again, I'm sure many of you are familiar with. So looking at this curve again, all right, so inflation, deflation. In a recruitable lung, what you will see is a picture very much like this. So the inflation limb goes up like this, and then the deflation limb, there's a gap, okay? So there's a significant gap here. And we can measure that objectively by putting a cursor at 20, so in the middle of the manoeuvre, okay? And measuring this value here, okay? And the magic number there is 400 mils, okay? And again, we'll talk about that later on. Anything less than that suggests that the lung may not be recruitable. So again, we talked about the different curves before. So if you've got a flat inspiration limb and then a flat expiration limb with not much gap between them, that lung is probably not recruitable. Oh, there we go. That's swanky. What else do I need to say about that? No, that's fine. And then finally, the third thing is the is the gradient of the curve on inspiration, okay, linear compliance. Again, we're going to talk about this afternoon, so don't worry too much about numbers and things, but the concept here is this part of the inspiratory curve, okay? So this gradient is also important. So if this as I've said before, if this is a flat line like this, and this gradient is more flat, for want of a better explanation, that lung is less likely to be recruitable, okay? Steeper gradient after the lower inflection point, okay? The steeper this is, the more likely that patient is to be recruitable, okay? So 3 things. Lower inflection point, is there one or not? Hysteresis, measure it, above 400 mils, and then this gradient, which you can measure using the cursor. We'll show you how to do that this afternoon, okay? And those 3 things together give you an idea of whether this patient's recruitable. So just in summary, if you've got as I said before, this idea that you've got a nice, curve like this, so low inflection point, steep inspiratory limb, hysteresis, gap here, probably recruitable lung. A line that goes like this and back down again, not recruitable. Yeah, that's just the same thing again. Okay, good.
Just briefly, will the patients eventually go on to recruit those alveoli, or could they potentially have a large region dead lung for the rest of his life?
During the manoeuvre, do you mean?
No. Just when you talk about recruitment, I mean, talking long and short terms. I mean, ultimately, will they recruit? He's gone to the ward now. Are they open those chunks of lung, or are they unusable for him forever?
Forever? Well, I suppose that's slightly difficult to ask, isn't it? I think I don't have evidence to give you for that. But if they're not I think the best way of looking at it is if you don't recruit the lung and don't use it for gas exchange and keep it collapsed down, I guess the less likely it is that you're going to have adequate gas exchange in the short term. Can I tell you that, give you an evidence, a study that says that over time, whether you recruit or not, improves, scarring, for example? My feeling is that that is the case, but I don't have the evidence base to give you. I don't know if Ian can come in on that. But I think what's becoming clear is that by recruiting lung early and using it for gas exchange, you're going to improve the progress of the condition. You're going to improve outcome, and therefore, by virtue of that, you're going to have a patient who does better afterwards. But I can't give you any additional information to that, really.
So I agree with that. The data's not there that an open lung is the way forward, but I think that's the direction of travel. The curve here, Mark showed, is just to assess for recruitability. Because if you find the patient's not recruitable, you don't go ahead and do that. You just infer for ECMO if you're really struggling.
Yeah.
I think as soon as the patient comes into the RC and ready, we do this. And if they suggest they're recruitable, we do a recruitment move instead of PEEP. And then with time, the delta P is low, the PEEP pressures are low. It works. It's nice and easy to do.
Yeah. Thanks. Thank you. Let's go back up again. Yes. So recruitment manoeuvre itself. So we've done our assessment. We've decided that the patient is recruitable. And how do we actually do it? So what are the preconditions that we require? So we need a passive patient. Okay. So well sedated, probably paralysed. Okay. We tend to paralyse the patients for these manoeuvres. What you can't have is the patient resisting, trying to take spontaneous breaths. So deeply sedated and paralysed, really. Again, we've talked about haemodynamics already, but if they're haemodynamically unstable, you probably want to defer this until you've sorted out the haemodynamics a bit better. Do they need fluid bolus? Do they need some vasopressor? Just beware of your cuff. So going up to a pressure of sort of 35, 40 here. Cuff pressure you probably need to address. Normally your cuff pressure would be a bit less than that, so you may get a leak. So consider transiently increasing your cuff pressure just for the duration of the manoeuvre. Okay. And obviously remember to take it back down again afterwards. Contraindications, some of which we've talked about already. Relatively straightforward, these really. Severe hemodynamic impairment we've talked about, high intracranial pressure, okay? Emphysema, so if you've got a patient that's got hyperinflated lungs, who's gas trapping, it's really counterintuitive, isn't it, to subject them to high pressure for a prolonged period of time, because all you're going to do is blow them up even further. So that's probably not a good idea. Likewise, if you've got a big leak in the system, it's all just going to come out through the leak and you're going to worsen your fistula. Okay. Pregnancy, contraindication to most things. Why are you here? Right heart failure. Okay, again, we're increasing intrathoracic pressure significantly. So if your right heart function is poor, that's going to be compounded significantly. So how do we do it? So probably the way that was done in the past, and has been done in the past, and I'm sure we've all done this, is manual hyperinflation. So get them on the bag, give them some hyperinflation breaths. Not reliable. How much you're squeezing, there's no way of measuring. Probably potentially injurious, actually. Probably not the way to go. Okay. I don't have any experience with this technique of using size, where you sort of periodically increase tidal ventilation or inspired pressures. I'm not really familiar with that. I've never used it. What we're going to talk about here is the sustained inflation method using the PV tool. Okay, and hopefully we'll be finished shortly. So, just to be clear, on the Hamilton ventilator, it's using the same tool, the PV tool. Okay, we're just using it in a slightly different way. So this time, unlike the assessment, okay, we're introducing a pause at end inspiration. So the idea is inflate the lungs, hold them open, and then during this time here, this pause, okay, the lungs should start to open up. Okay, and that's basically the premise of the thing. So here you can see a curve there. So tidal ventilation here. This is where the manoeuvre starts. So this is where you ramp up the pressure. Okay, so we tend to use a ramp speed of 5. We'll talk about the numbers in the workshop. Up to your top pressure. So again, 40. We sometimes use 35, 40. And then hold it. Okay, and this is the time during which your recruitment should hopefully be happening. Then back down again. Okay, and tidal ventilation here. You set PEEP. The PEEP beforehand that you're already on is here. Where is it? Yes, there. And then you have the ability to change the PEEP setting for afterwards. Okay. So this is the PEEP that you finish on, and that will be here. I knew you were going to ask that. So we're going to talk a bit about that in the workshops this afternoon. We could talk about this for quite a long time. Okay. Broadly speaking, we go back to our curve. No, going the wrong way. Yeah. Broadly speaking, there's 1,000,001 ways of setting PEEP. There's 1,000,001 ways of assessing how much PEEP you need. Okay. We can talk about sequential reduction of PEEP, and various other things that that can be done. But broadly speaking, the lower inflection point here, once you get down to that level, the lung is de-recruiting. So in the past, I've tended to use the lower inflection point to set my PEEP at. Now actually what's becoming clear, I think now, or clearer should I say, is that this probably isn't enough. So the PEEP needs to probably be somewhere between. Hamilton gives you a point of de-recruitment, okay, which I wasn't going to talk about, but that's this value up here. Probably the PEEP needs to be somewhere between those 2 points, okay? But lower inflection point is probably too little, okay? But what you can do is you can set your PEEP very high and gradually reduce it, and there's ways of looking at what is the best PEEP for that patient, but I don't really want to go into too much detail at this point now. But going back to what we said right at the beginning, what's becoming clear is we probably underutilise PEEP. We probably don't use it enough in this setting. Right. So conclusions, finally we got there. So what have we talked about today? So we've talked about having the need for having a recruitment strategy, haven't we? And the point of this is to try to reduce ventilator-induced lung injury and ARDS, okay? That's the whole point of this. We've talked about this difference between PEEP on the one hand, keeping the lung open, and recruitment on the other, opening it, okay? And the fact that PEEP isn't and shouldn't be viewed as a recruiting force. We've talked a bit about how to assess whether a patient's recruitable or not. We've also talked a bit on how to do a recruitment manoeuvre, all right, and we're going to have another go at that later. I think key message really we talked about as well at the beginning is that we should be doing this early, all right, and then I've sidestepped the issue of talking about PEEP and how to set it, but we can talk about that a bit more later on. And that's it.
Thank you, Mark.
No problem.